Dear listeners, we are happy that you are interested in the application possibilities of electrical stimulation in the clinical practice of physiotherapy. All the information on the slides was prepared during the implementation of the European Union funded Erasmus Plus project, which was called Clinical Key for Electrical Stimulation. The leading partner of this project is university from Turkey named Pamukkale University. Also, we have more project partners from Turkey and the Turkey universities. It's Hatay Mustafa Kemal University, Bashkent University, Suleiman Demiral University, Budur Mehmet Akif Ersoy universities. Also, we have partners from Romania, University of Craiova, and Lithuania, Šiauliai State University of Applied Science. In this project, there are actively participating and the physiotherapy associations from Turkey, Romania, Lithuania, and Estonia. I want to introduce to the Model 3 electrical stimulation for the health muscles, and this model's subtopic 3.7 point electrical stimulation for patients with sport injuries. This subtopic was prepared by physiotherapists Dovydas Gedrimas and Vaida Aleknavičiūtė Ablonskė. In introduction, following injuries to joints and muscles, the injured parts of the body are often immobilized for some time to allow the damaged joints, bones, and muscles to heal. While immobilization is usually necessary, it has harmful consequences on the function of the muscles, and recovery is often slow because muscles have to deteriorate during the period of immobilization. In these cases, electrical stimulation of the muscles during the period of immobilization and afterwards is beneficial and speeds up recovery. Studies showed that healthy inactive muscle tissue generally atrophies at approximately 0.5% per day. Of particular relevance is the time course of muscle atrophy, with the first 1-2 weeks showing the greatest related loss of the muscle mass. During this period, 150-400 grams of the muscle tissues can be lost from a single immobilized leg. In the line with this lead loss of muscle strength and decline in a local insulin sensitive occur rapidly with the first 1-2 weeks after the immobilization. In these cases, electrical stimulation of the muscles during the immobilization period and afterwards is a beneficial speed up recovery. Inactivity of other joints of both upper and lower limbs is likely to have similar effect on the muscles involved in the movement of these joints as the described for quadriceps femoris muscle. They become atrophic, produce less force, and are more fatigable. Their recovery is likely to be more complete and faster if neuromuscular electrical stimulation is used both during and after immobilization. There is much evidence that when the quadriceps femoris muscles are electrically stimulated during the period of immobilization and subsequent recuperation, the recovery of force of the muscle is more complete and the period of restricted movement is shorter than without this intervention. Knee injuries. Knee injuries affect 80% of sport people, particularly those engaged in rugby or football, and it follows that even in cases where surgery is not necessary, a period of enforced rest will quickly lead to the muscle deterioration. Reduced ability to make voluntary contraction of the quadriceps femoris muscle is a common problem after knee injury, even though there is no damage of muscle or innervating nerve. This condition is often referred to as arthrogenic muscle inhibition. Muscle weakness after surgery or injury can be partly explained by atrophy of the muscle, but also by this decreased ability to activate the muscle fibers available. The latter is suggested to be a protective reflexive response to alter the neural drive to the surrounding musculature after the injury, hence precluding voluntary muscle work and normal function. In most cases of knee immobilization, neuromuscular electrical stimulation is effective in preventing the decrease in muscle strength, muscle mass, and the oxidative capacity of tight muscles. Most studies indicate that neuromuscular electrical stimulation is more effective in preventing muscle atrophy when compared to no exercise, isometric exercise or quadriceps femoris muscle group, isometric or contraction of both hamstring and quadriceps femoris muscle group, and combined isometric exercise. Neuromuscular electrical stimulation has been attempted in cases where voluntary muscle contractions are inhibited after injury or surgery because of its ability to induce action potentials in the motor nerves and overrule inhibition, thus making strength exercise possible. For clinicians working with knee injury patients, neuromuscular electrical stimulation is a useful tool in rehabilitation when traditional exercise are limited by inhibition. Neuromuscular electrical stimulation has been proven to be effective for preventing the reduction of the muscle protein synthesis, muscle mass, and strength after knee injuries. Neuromuscular electrical stimulation also attenuates loss of oxidative enzymes activity and lack muscle mass or strength in subjects submitted to 30 days of the bed rest. Dirk with the colleagues had found that neuromuscular electrical stimulation increased muscle protein synthesis and inhibited the activation of protein degradation pathways in subjects with the knee immobilization for 5 days, thereby preventing muscle mass loss. In addition, neuromuscular electrical stimulation increases muscular and functional resistance, especially in clinical patients, as well as muscle oxidative capacity and maximal oxidant consumption, VO2 max. In addition, similar to endurance training, neuromuscular electrical stimulation increases antioxidant capacity, therefore providing useful in reduction the redox imbalance predicted by this use period. Strengthening in knee injury cases. The recommended neuromuscular electrical stimulation parameters for quadriceps femoris muscle stimulation are high voluntary pulse galvanic current, 57 Hz frequency, pulse width 200-400 microseconds. The duty cycle should be appointed to ratio 1:3. For example, 5 seconds of work and 50 seconds of rest, or 10 seconds of work and 30 seconds of rest. Intensity when selecting milliamperes parameters should be set to the max tolerable intensity. Usually, it is followed by visible muscle contraction. Stimulation can be used for 30-50 minutes a day. The recommended neuromuscular electrical stimulation parameters for lower limb atrophy prevention are frequency 100 Hz and pulse width 400 microseconds. This stimulation should be used for 30 minutes twice a day. Pain management for the knee pain. Electrode placement for the quadriceps femoris muscle stimulation is shown in Figure 1. In the left side, you may see adhesive cord electrodes. In this right side, self-adhesive wireless electrodes placement. In both cases, the electrode is placed on the beginning of the quadriceps muscle femoris, and the other electrodes are placed on the motor point of the quadriceps femoris muscle. During the electrical stimulation, patient should lie on the couch and his knee should be slightly bended. Pain control in knee injury cases. Transcutaneous electrical nerve stimulation electrode placement for the knee pain is shown in Figure 2. To reduce knee pain, electrodes are placed around the knee joint and connected lengthwise. It is very important that during the electrical stimulation, patient feel comfortable and knee should be slightly lengthened. Parameters should be used according to the patient's condition. Achilles tendinopathy. Achilles tendinopathy is one of the more common overuse injuries sustained by runners with reported approximately 52% lifetime incidence in the recreational runners. Pain is located to the mid-portion 2-6 cm proximal in the insertion or insertion of the Achilles tendon. Symptoms are often provoked during tendon loading activities, which include running, jumping, walking uphill or ascending and descending stairs. Galvanic electrical stimulation can affect nociception through segmental inhibition, descending neural inhibition, and several other neuromodality mechanisms. It uses direct current to facilitate movement and tissues, promoting blood flow and potentially aiding in the healing process. Pain control in Achilles tendinopathy cases. Transcutaneous electrical nerve stimulation is a common modality used by rehabilitation clinicians and has been studied employing a variety of pulse frequencies, intensity levels, and durations, making it difficult to determine its effectiveness. And electrical stimulation that is delivered at high intensities, just below motor threshold through pain threshold level stimulation, can reduce central sensitization. Transcutaneous electrical stimulation can restore central inhibition and increase pressure pain threshold at the local treatment site and sites beyond, and may thus be useful in reversing some of the adaptations that the nervous system makes when confronted with a chronic pain. Berzens, with a colleague, investigated the effect of burst transcutaneous electrical nerve stimulation on collagen formation after Achilles tendon suture in man. Among the 20 patients, 80 participants completed the study. 9 participants underwent transcutaneous electrical nerve stimulation and 9 received simulated treatment. It was found that the group who received burst transcutaneous electrical nerve stimulation treatment experienced effective proliferation of the fibroblasts and production, maturation, and organization of the collagen fibers. Therefore, evidence suggested that transcutaneous electrical nerve stimulation could have a positive influence on the Achilles tendon healing in male. To facilitate the tendon healing and reduce pain burst, transcutaneous electrical stimulation can be used. A pulse duration of 300 milliseconds, internal frequency of 100 Hz, burst frequency of 2 Hz, variable amplitude according to the patient's tolerance without visible muscle contraction. Treatment can be performed for 5 days a week. As you see in the picture, one electrode is placed above the place of pain and the other electrode is placed below the place of Achilles tendon pain. Ankle injuries. Ankle injuries are very common between professional athletes and recreational sports. With an incidence of the general population of the United States of 2.50 per 1,000 persons each year. The most common injury mechanism is combination of inversion and adduction of the foot in plantar flexion, supination. This injury mechanism can cause damage to the lateral ankle ligaments, most of these lesions in particular. Incomplete tearing of ligaments can be treated conservatively. Pain control in ankle sprain cases. Standard of care for lateral ankle sprain includes protection, raised ice, compression, and elevation. However, sport medicine's clinicians continue to incorporate electrical stimulation during the acute and subacute phases of healing in an attempt to expedite the process and allow for an early return to participation. Pain and edema as a result of structural damage often results in functional limitation. Preventing edema formation or enhancing resolution of edema and continuously modulating pain during rehabilitation may allow for the quickness function progression and subsequently may decrease the time lost to injury following lateral ankle sprain. The 25 minutes application of non-tetanic 5 Hz neuromuscular electrical stimulation was suggested to generate hyperfunction of the vascular wall surrounding the skeletal muscle, thereby decreasing the inflammation restored, a measure by a reduction in creatine kinase. So for the pain control in ankle sprain cases, the transcutaneous electrical nerve stimulation device unit should be adjusted to deliver a biphasic current with a symmetrical waveform. Following stimulation parameters are frequency 50 Hz, 3 seconds RAM uptime, pulse duration 250 microseconds. If using on-off cycle, it should be adjusted to 1:2 ratio. For example, 50 seconds on and 30 seconds rest time. In this slide, you may see the example of the transcutaneous electrical stimulation electrodes placement for the ankle skin. As you see in the picture, one electrode is placed above the place of pain and other electrode is placed below the place of pain. Shoulder injuries. The shoulder is the most mobile joint in the human body. It allows the upper extremity to rotate up to 100 degrees in 3 different planes, enabling the arm to perform versatile range of activities. This mobility comes at the cost which leaves the shoulder prone to injury. The higher risk for these injuries is for overhead athletes in sports when the throwing motion is essential. Also, contact sports such as rugby tend to have the increased risk of shoulder injuries. While a single traumatic event may cause injury, more commonly it is repetitive overuse that leads to the failure of one or more dynamic shoulder girdle structures. Strengthening in shoulder injury cases. Usually, anterior shoulder dislocation or subluxation are the main injuries that require rest and rehabilitation before returning to sport. Restoration of dynamic joint stability is initiated in the acute and subacute phases after the split is removed. Neuromuscular electrical stimulation of rotator cuff structures, particularly the posterior rotator cuff, may also be helpful adjunct for muscle requirement during the acute process. It is recommended to use 10-36 Hz frequency to manage shoulder recovery after the subluxation. In this slide picture, you may see the example of electrode placements for infraspinatus muscle strengthening with acute muscle contraction. As you see in the picture, one electrode is placed on the beginning of the muscle, the other on the motor point of this muscle. Infraspinatus function stimulation is shown here. The patient is performing the movement along with the electrical stimulation current. Pain control in shoulder injury cases. In this slide, you may see transcutaneous electrical nerve stimulation electrode placement for the shoulder pain. Pain management in the shoulder should be accompanied using transcutaneous electrical nerve stimulation following instruction for the acute pain management parameters of the electrical stimulation. Wrist and elbow injuries. Approximately 25% of all sports-related injuries involve the hand or wrist. Common injuries generally fall into two different categories: traumatic, acute, or overuse, chronic. Sports such as hockey, football, or wrestling tend to result in more traumatic injuries than others. The main traumatic injuries in this region are muscle strain, joint dislocation, ligament tears, inflammation, and fracture injuries in fingers. Chronic injuries are more common in sport that requires repetitive motions. The main overuse injuries are tendonitis, tendon dislocation, nerve injuries, and stress fractures. Pain control in wrist and elbow injury cases. Electrical stimulation can be used as an additional measure in acute injury treatment protocols. Usually, electrical stimulation is used for pain control in acute stage of trauma. Transcutaneous electrical nerve stimulation can be used on a site of pain if there are no contraindications, such as open wounds or fractures that need immobilization. Parameters for this stimulation are the same of those for acute pain management. High-frequency transcutaneous electrical nerve stimulation is recommended in this phase. Stimulation at 110 Hz can help to reduce pain. Impulse duration 200 microseconds. Transcutaneous electrical stimulation recommended to use 20 minutes duration for the single session in a day. If an athlete's condition becomes chronic, the physiotherapist may choose low-frequency transcutaneous electrical stimulation. The procedure parameters are 20 minutes at 410 Hz, impulse duration 200 microseconds, electrodes are placed on site or around the pain area. Thank you for your attention. In this slide, you may see the references of all literature that was used preparing these slides.